Yeah, keep EBU ready. Then cyan blue ready. You can switch on IRBP. I'm just sending guide. Yeah, after that you start. Okay, you can start IRBP. Pressure. Yeah. Keep IVUS ready. Come to epicord, please. Okay, go to epicranial. Heparin antichon. 10. Okay. Keep second wire ready. Renato. IVUS here, please. Yeah, I think that's fine. Okay. There is air. Okay, don't inject. There is air. I think there is good space. Even IVUS catheter is gone. Shall we directly go with IVL? So you tell us the size. It's bifurcation. This is LCH. It's all air artifact, I believe. So we'll just do Ostio LAD to LM again. Okay. Okay. Just stop. I'm going down again. This is LCX. I think this LM is fine. Okay. Only from osteo is this way. Osteo LAD. Yeah. Okay. Okay. Give us sizes. Yeah. We crossed into LAD, so we know this is high creatinine, and so you can see there is a good space in LAD, and you know, it's minimum lumen area is like 1.5. Yeah, you can increase actually. See, lumen is a kind of 1.5. Yeah, give me IVUS from diagonal. This is diagonal, so we crossed into diagonal with Renato wire. So we'll do IVUS from diagonal. Just give IVUS. We can see this is severe calcium based on fluoro, and if you look at entire IVUS, the arc of calcium is completely to one side. So yeah, so this is IVUS from diagonal. Is moving. So vessel looks almost like 2.5 mm. So, and as we come closer, yeah, we are coming close to ostium. Yeah, we can see there is a tight lesion at ostium. Probably we can even calculate lumen area and see. So first, what I'll do, I'll just open. I think that's fine, right? So yeah, okay, we'll open. Yeah, if you tell us the size, I'll take a cutting balloon for ostial diagonal. Can you sedate, please? Yeah. So just give me the size of diagonal. Okay, 2.9, 3.1. Come, take 2 or 3, you know, 2.7, 3.2. All right. Yeah. Yeah, that's EM. So it's almost like 3.1. So I think I can take a 2.5 cutting balloon, right? So give me 2.5 Wolverine for diagonal. So we are doing, can show them the ostial diagonal, okay? Yeah, you can see this is ostial diagonal. So you can just rotate in longitude. You have to still go back. Yeah, back. Yeah. This is where, you know, you can still adjust. Lumen area is not that much, you know. Okay. Yeah. So this is ostial diagonal. You can see a lot of block area, and yeah, and it's close to 3 mm vessel. So that's why we decided, you know, to dilate with a 2.5 cutting balloon. However, our idea, and it's a very discrete flock, that also you can show the length of the flock. You can see in ALA, in longitudinal view, the flock length is very short, okay? So it's less than 10 mm, so it's very short, you know, length flock. Array, fluoro big screen, please. So, lesson, tamam. Yeah. So, yeah, that's the reason. Okay, right. Guide, please. Yeah, dilate 10, 12, 14. Yeah. So we are at 14 pressure, 30 seconds. Okay, timer. Yeah, negative. Yeah, dilate 14, 16. Yeah, 16. Maintain 16. Right. So you can see the expansion is good. You can also see in two views if you want. I mean, it's always ideal, take two views. For this area, it is cranial and cranial. Okay, negative. Since I'm going to do anyway IVUS again, so yeah. So we are also dilating LAD just to get a sense of how it behaves. Go to 18. So what's the size of IVL you recommend for LAD? Proximal to diagonal. Negative. Yeah. Dilate. 18. Proximal to diagonal. Done. No, but here EM is not clear, no? No, even here it is not clear. So I think you have to go to the next image where there is no air artifact and measure. So I think from 3 o'clock to 9 o'clock you measure. All right, that's a EM, yes. Or you can just put an AL, yeah. But you don't have quarter sizes, right? Either I have to take 3 or 3.5. Whether this allows 3.5. No, I think we'll just do with the 3. Okay. Okay, give me a 3 IVL. That's a problem, because there is calcium everywhere. So it is really difficult. I feel, we can go up to 3.5 as well, but let's see, we'll just try with the 3 and then see. So this is distal to, so that's a, okay, closest spot, where there is no calcium, right? This is distal to diagonal. So, okay. So if it is 4 distal to diagonal, it should be 4 even proximal to diagonal. See, for a problem with proximal to diagonal is there is all calcium everywhere. We are not able to get a right spot, and EM is not greatly visible. So I think we'll take 3.5. Okay. So yeah, you can show that again, that distal to diagonal spot. Yeah, but anyway, IVL we are going to do only proximal to diagonal. So we are not going to distal to diagonal. So give me 3.5. Okay, we'll take IVL. We'll do IVL, and then we have to even prepare lesion distal to diagonal, right? So that we'll do with cutting balloon. So we took 3.5 IVL. So yeah, give it on LADY. So you can see, we are not giving any contrast to the patient. So, and all the while, keep an eye on ECG. Any ECG changes. Yeah, has patient complaining of anything? Yeah, so we are going ahead with, first inflate 4 atmospheres. See, there is no air first. See, there is no air. Okay, now, yes, yes. Till the color changes, and then. So this is Merrill IVL, so which we are using. Yeah, negative. Yeah, I'll just come back. I think we have to deliver maximum here. Yeah. 4. Yes. Okay. Yeah. So you can also mark minimum lumen areas before there. So you have to show us minimum lumen areas after IVL. Okay. There is air. Remove it. Remove air, please. If there is air, your pulses becomes ineffective. Okay, so it's very important. There shouldn't be any air. Okay, so dilate now. So we made system air free. That is very important, when you're doing IVL. So there shouldn't be any air in the balloon. Yeah. Okay. Now few pulses, yes. And as you keep giving pulses, air will appear. So and you have to de-air it. So that's one of the reasons why IVL may become ineffective. So. Okay. Yeah. Pressures, okay. Okay. Go. Yeah. Negative. Okay. So pressure is fine. Here. Yeah. The size may not be that big. So okay. Pressure. Negative. Negative. Start IABP, please. Why you stopped IABP? Yeah. Do it. So we are also doing just immediate post diagonal since I was showed 4 EM there. Yeah. Let it flow. Do it here. So like just rest here. Okay. How many more pulses? One. Okay, finish. We'll finish that and then do IVUS. IVUS both from LAD and diagonal. Okay. So we're giving last pulses done. So all 80 pulses done. This is Mason IVL. So what we'll do now, we'll just do IVUS from LAD and diagonal, and then we'll take a call. Just okay. You just give me a cutting balloon 2.5. I'll just dilate distal to diagonal once. So there you can just tell us the size of the vessel beyond diagonal. Yeah, 2.7, 3, 2.9. So okay. Okay, so I'm just taking 2.5. So we'll go to only 10, 12 and come out. Okay, dilate 12. Okay, negative. Yeah, dilate. So we're just dilating distal to diagonal 12, 14. Okay, yeah. Yeah. There even we have done even IVL also. The area which you showed for post diagonal. So we did even IVL. Okay. Yeah, negative. Give me IVUS now. This is IVUS from LAD after 2.5 cutting balloon distal and 3.5 IVL, proximal. I think that area needs little. We have to. Yeah. This is proximal LAD. So you can see there is a huge luminal gain. Yeah, there are ruptures, clear ruptures in the calcium, you can see. But the only problem is, it's a sheet of calcium. So you can just tell us what's the luminal gain in LAD and show us the breaks in calcium. So then we have to take a call on, yeah, okay. So then we do IVUS. So there is still some clock, I think, beyond diagonal, which we have to prepare. So, but that's only a soft block we can clearly see. And almost like 3.4, 3.5, right? So yeah, I think we can take a, yeah, yeah, you can also give stunt size from, yeah, distal reference to ostial LAD. So take proximal reference to ostial LAD. In ALA, you shift proximal, yeah, to ostial. Yeah, 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 yes, yes. So what's 34? I think. Oh, there is a bridge. Oh, go down and show the bridging. You can play. Go to the tip and play. Distal most. Go to distal most. Play. Not so prominent. Not so prominent. Anyway, so you can show. Yeah, that's the length, right? 34 millimeter. And the reference is like 3 point, EM reference is like 3.3 something, okay? So I can take a 3 stunt and proximally we can dial it with 3.5. So keep a 3 stunt ready, yeah? And yeah, so then you show what's the luminal gain proximally? 5.7, okay? But you can also see a clear crack in the calcium. So yeah, that's a clear crack in the calcium. Yeah, next, go down. And at the same point, the crack is almost continuous. Okay. So, and it's only kind of, only at one place it is like 230, 260 degrees. Rest of the place it is like a 180-degree sheet. So most likely, we should get a good lumen area even if we stunt. So yeah, you can clearly see, from 2.1, 2.1, the lumen area went up to nearly 5, yeah, 4.5 and 5 above. Okay, right, come. So we are doing, for ostial diagonal. So IVUS, you can see, yeah, IVUS live. Okay, so this is ostial diagonal. So we're doing from diagonal. I think what was the MLA before? 2.2 or 2.3 something? 2, okay. Yeah, there is a small dissection, but it's okay, nothing to worry about that dissection. Yeah, now the lumen looks wider than before. Anyway, we'll calculate the lumen. I think it's fine. Okay, right. So we have to prepare, there is a block, right? Just beyond diagonal. You can give a 2.75 balloon, please. Yeah, we'll just prepare the block below the diagonal, and then we'll show you how to position stunted ostium by using IVUS, because that's one step, which takes a lot of contrast, especially a patient where we don't want to give contrast. So, yeah, I think almost 4.2 ostial diagonal. Yeah, anything beyond 4. 4 is a good. What's the distal reference? Mark as reference. Bookmark. Yeah, mark. Right. So throughout, you have a good area, right? So lumen areas are quite good. Ostial diagonal lumen area is almost close to. So we are on LID, right? So close to. I think this is Dalet. So no need to worry about diagonal. Now we can go ahead. 14, 16. Yeah. So now the next step is ostial positioning of stunt. So we are okay that, stunt would definitely expand now. So we have seen cracks and there is a huge luminal gain. So even without stunting, the lumen is close to 5.5 in proximal LAD. So that's a good, okay, negative. So I think, so we are positioned in a good state to even stunt. Probably can show them the stunt size. Okay, give me IVUS. on LAD. Yeah, this is the distal vessel. You can see lumen itself is like 2.7 or 2.8, close to 2.8. Okay. So as per our discussion, 10% more than the lumen will become 3. So you can safely take 3 if you calculate with the lumen because there is no block area. But if you calculate with EEM, you can see here it's almost like 3.2. So quarter size less again comes to 3. So I mean that's how. Okay, you can calculate out. Okay, so I removed diagonal wire, as it came out. That was not my plan. Light. So you can see this is how we can reposition. Yeah, osteo. Yeah. So you can. There are nice cracks in calcium. So I'm coming back. You can see this crack in the calcium is quite good actually. You can, yeah, at this, see, can you see it's all dissected, cracked, and even that crack extended into the deep tissue. Yeah, this is one branch. Yeah, okay, I think that's where we can end, right? So yeah, this is where I can end. Right, come to epicaudal, please. So in IVUS, we are marking IVUS. You can see this is the ostium. And what I'm doing now, so we will give you a little contrast. Yeah, so, and so we'll mark, yeah, that's IVUS. So you can even use calcium as a marker as well. So, okay. So this is the first injection I gave. Perfect. So give, yeah, okay. Okay, give a stunt. I think 34, we'll take 38. Yeah, 338. And then give us 3.5 balloon, 3.5 NC. So what we have to do is, since synergy is a stunt where marker is just proximal to the stunt edge, there is 0.3 millimeter gap between stunt edge and the marker. So we'll keep marker exactly proximal to the transducer position. So that's what we are going to do, and deploy the stunt. The same view, please. Angle same. Yeah, small check. Don't move the table. Okay. Wait. Don't inject. No, only small injection. I want to see proximal. I think that's perfect. Yeah. Small semi. Yeah. Deploy. Yeah. 11. Okay. Give us 3.5. So you mark and then you deploy. So now again deploy. You make 3.5, 12, 40. Yeah. Yeah. Negative. So now what we'll do is we'll optimize proximal stunt with 3.5 because we know that's a bigger vessel. And we can all the while keep watching, ECG for any occlusion of, diagonal. So there is no ECG changes as such here. So we're not injecting, we are going ahead with no complaints from patients. So we are going ahead with 3.5 post dilatation. Anyway, yeah, dilate from here. Yeah, go to 18. So yeah. So this is a minimum pressure which we use, so in such patients with calcium, 18 atmospheres negative. Yeah. So go to 24. So you can see it is nicely expanded. Yeah. Negative. We are not taking orthogonal fluorous since anyway we are going to do it with the IVUS. Yeah. Dilate. 24. 38. 28. Out. Right. So I think We are done. So we'll take IVUS. Keep JR ready. So we're doing IVUS after post-dilatation. Yes, IVUS on big screen, please. So what, we got a length of 34, but we took 38. So it's good landing, so no issues and no bridging. Yeah, so the good expansion, right? That's a diagonal. So, but never interpret, side branch from main branch IVUS. So, but anyway, it is open and there is no increased speckling. That makes our decisions clear. When there is no increased speckling, you can forget about it. No need to just rewire. And this is the area you can see where exactly there was a break in the calcium, that where it got expanded nicely. I think 1 mm inside where we thought, but it's good, overall, right? So perfect. So you give us all the areas. Okay, full screen IVUS, please. This is distal reference. Stunt is there, no, already. Go down, down, down. No, no, stunt is there. Go down, 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 down. Yeah, this is distal reference. Mark as bookmark. Mark as reference, right. So 4.1 is the distal reference. And you can see distal to diagonal, we are almost 5 to 6. It is way above, your distal reference. And proximal to diagonal, yeah, I can see it's almost like 7 to 8. Yeah, it's almost 7 to 8. It's 9 here, 10 here. Yeah, it's almost above 8. Come close to ostium, so nearly 10. Okay. Yeah. And this is where we ended. You can see that's a ramus bar, first diagonal. So that's where we ended. And you can see you can come proximal. You just take arrow onto ramus, so that viewers will understand. Yeah. So that's the ostium. Then you just come proximal. So proximal, yeah. There is some flock here, but you can see lumen area is almost like 10 mm square. So we wanted to land stunt here, but it's okay. You have a 10 mm square lumen area and no issues. So not much of dissection, but there is a calcium disruption, but it's okay. Nothing will happen. So I think we are good. So pressure can be reduced, please. So you have to make them understand the flow, how we are saying diagonal flow is good. Yeah, that's a diagonal. Stop. Yeah. Can you see the speckling? So pattern, the speckle pattern is same as main vessel. That says, yeah, I can keep dyno review. So speckle pattern is same. There is a block in the ostium, but it's okay. We know there is a block. It's a very short eccentric block, and there is also a small dissection. But open vessel is our criteria. So the vessel is open, speckle pattern is okay. So I think we are good. So I don't need any injection, but I'll give one epicranial for the sake of you guys to show you. Okay. So I think overall we gave just max 5 to 10 ml. We gave only two injections, even positioning. Most of the contrast here is for positioning, so which we did with IVUS. You can see diagonal is quite good, flow is good. Give JR. So we are moving on to right coronary now. Okay, keep sand blue ready, and again IVUS ready. Okay, IAPP on. Right, pressures nodded. కొంచెం మళ్ళీ start చేసుకోండి. IVUS please. So we are in RCA. We crossed. You would have observed, we have not given any injections. We crossed. Now we'll do IVUS. So I'll mark, distal reference using IVUS. I'm pulling IVUS back. You can see where the block appears. Yeah, I think, yeah, this is where the block is. So I'm going just distal. Yeah, I think this is the distal reference. So you can even calculate length, without much problem. Yeah. Node is on. Yeah, this is tight lesion. It's mostly fibrocalcific, predominantly fibrous. Okay, this is the proximal reference. So now its length is like 38 millimeters. There is another lesion in mid RCA. Just assess how it is, but that was a bit eccentric. Yeah, you can see this is a lesion, but I think MLA looks good. Based on MLA, will decide whether to touch it or not. Anything more than 4 square, I think no point in touching. He's a 82-year-old guy, right? I think you can give us that 2.5 cutting balloon, which we have on table. So what's, so 3 is lumen. 3 to 3.1 is a lumen, right? So we can easily take a 338 stunt. But what is the size proximal to crux? So here almost like 3.5, Okay, now you show us what is the MLA in the middle lesion, mid RCA lesion. It's proximal. You can see in longitudinal view. Yeah, okay. So it's 6.5. So 5.7, 4.8. Okay. So anything more than 4, no point in touching, in this patient. So I think it's good. No need to touch, mid RCA lesion. So let's prepare the distillation. And you can see, go to distillation. And it's clearly fibrocalcific. Like, you can even take 3.5, but we don't have 3.5 cutting. So on table, I have 2.5 and 3.5 balloon. So what I'll do, I'll just do a cutting with 2.5, then I'll dilate with 3.5 NC, since it is already on table. Am I 3.5 NC, keep it ready? Yeah, so just dilate here, 18. So it's very small for this vessel. Okay, keep it, yeah, dilate, yeah, 3.5 balloon, 3.5 balloon sister, yeah, negative. Yeah, just show me the point where we started IVUS. Yeah, keep this on the other side. So this is the distal reference. So don't go with your cutting balloon, beyond this point. So yeah, that's the idea. Okay, dilate. So keep it in the same view, please. Yeah, yeah, negative. Yeah, dilate. Yeah, 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 negative. Give me 3.5 balloon. So what I'll do, I'll just take 3.5 balloon and dilate and see in two views for this region, alveocaudal and alveocranial, or the right views. We'll take two orthogonal views. If it is expanding nicely, then we'll move on to stunt. Keep 338 stunt ready, please. 338 synergy. Yeah. So now, can you show me the proximal reference here? Go back. Yeah. This keep this here. So what we are making sure is we are not going beyond proximal and distal reference for balloon inflations. Yes, dilate. And this is the tightest point. Go. No. 12, 14, 18. Yeah. I think it's nice expansion. Yeah. You can just come to yellow caudal quick. You guys can see it is expanded. Cranial quick. Yeah. Okay. So I think it's nicely expanded out. So take stunt. So length of the stunt. Okay, we'll do IVUS once again. Give us IVUS. give a little NTZ elevations there. Oh, it's okay, no problem. Yeah, this is block. So I think from here we can take. You gave NTZ, right? Yeah. What is the minimum lumen area before? 2.7. So you tell us what's the luminal gain now, so that they also understand that 3.5 NC has done its job. We don't need to modify anything further. You can see there is a good, block modification, and there is a huge luminal gain as well. So it's almost, I would say, probably more than 5.5, so in this zone. So it's a perfect time, you can go ahead, and stent it. I think that's fine. Okay. Right. So again, reconfirm the length. Wait, don't open. You have 42? Huh? 42. Okay. So give us 48 then. Huh? Give us 48 then. Yeah. Give 48. Play it from B1. Play. No, there is no slow flow. You can see the speckle pattern is good. Keep a distal marker here. Yeah. Take a cine. I'll go a little down. No injection. Yeah, deploy. Nicoron iche. Give 3.5 balloon ready. 12 out. Let's go to 14, 16. Yeah, give me 3.5 out. It's a Nicoron. Okay. We are just giving some Nicoron. Give me 3.5 balloon. We're optimizing, the proximal stent with 3.5, and then we'll just come out after final IVUS. So Dr. Sri Krishna has a doubt because there are some ST elevations seen in inferior. So there is no increased speckling observed in IVUS. So that's why we just gave some Nicoron. Yeah, delete 14, 16. Yeah. Negative. Yeah, go to 18, 20. Yeah. 24. 24. Yeah. Okay. Negative. Out. Give some NTZ, please. Okay, there is some jump in ST. So we'll try to give some NTZ. NTZ, please. Yeah, I think whenever we are dilating that proximal lesion, probably it is creating some problem. Okay, let's wait. Can give some more Nicoron. It is settling? Yeah, okay. Give IVUS. Yeah, I think ST is settling now, so yeah, we'll give IVUS. We'll do IVUS and then come out, okay? Yeah, we are just doing final IVUS. And you can see those, I'm just injecting normal saline, which is really, we went too far. Yeah, I think landing is perfect. I think it's fine. Opposition. If you want, you can even dilate a little bit. Give us a 3 NC. From here, we dilated with 3.5. I think it's fine. So proximal it is fine. So distally, we can have a little bit more expansion. Is there any geographical miss? You can see the block area, just proximal to stent edge. Anyway, we're not going to do anything, but we'll just show you what is geographical miss. This is all the lesion which we decided not to cover up. Okay. Okay, give me 3. Since we felt we can achieve more display, so we are just dilating with the 3 balloon. Stunt boost. So what's block area just proximal to the stunt? Just proximal to stunt. Proximal to stunt. Proximal. Here. Yeah, I mean, theoretically you can say there is geographical miss, but it's okay. You know, there is block everywhere. So, yeah, dilate. 14, 16, 18, 18, 20, 20. Yeah, 20, 22. Yeah, I think that's perfect. So rest all we dilated with 3.5. Don't do too much because again you'll go into no flow. And speckling is good, right? Yeah. So we are done. So do you guys want contrast? We are okay to come out, without contrast. Okay. I'll give you one shot for your sake. I think we are good. And there is a mid-arterial lesion we already mentioned. So the lumen area is almost like 4.5 mm squared. So we don't want to touch. And we just came out. Show the last injection to them. I think we finished it in maybe number of contrast shots. Can you show from first? Thin plus max. We used 20 around 25 ml. So yeah, we'll show you all this stuff we did, without contrast. You can see this is the only step in LAD where we gave contrast. That is for ostial positioning. Guide by IVUS. Next. And then stunt injection positioning. Next. Yeah, this is the last injection. Again, this we did only to show you. Otherwise, I generally avoid these injections also. Next. So this is where I injected because there was some ST elevation, which Krishna pointed out. So that's the reason I thought of injecting. So see the flow. So overall flow is fine. Next. And then we stunted at stunt positioning. We gave one more injection, and this is a final injection. So that's all. It's total 25 ml. Okay, fine. So can we wean off IABP now?